Welcome. Thank you for joining us for another pop-up presentation. As a reminder, these pop-up presentations are designed to take place whenever a PD opportunity pops up or whenever a PD need pops up. So today we'll be speaking about supporting underweight children. And so we have a few pieces of housekeeping to go over. First of all, as I just said, this presentation portion or the first half hour of today's gathering will be recorded and shared on the resource YouTube channel. You can find a link to that on the EINWI website. If you received this link to this pop-up presentation from a colleague, or maybe you stumbled on it on the website, we want you to do it right away. So we encourage you to join our EINWI.org mailing list, and then you'll get information as these pop-ups are scheduled. You can sign up for that by going to EINWI.org, scroll to the bottom of the page, and there's a sign up box right there. To cut down on background noise, we ask that you just keep your mics muted during the presentation. The second half an hour of our time together today will be spent in a Q&A session that will not be recorded, and we invite you to please unmute. Please hold any discussion questions for that Q&A session. If you just have a point that needs clarification during that first half an hour presentation, you can put that in the chat. There's a bunch of us here from the resource team, and we can sort of man that chat so we can keep things moving. And then finally, we just always like to have a caveat here that while we are so excited to welcome and wholeheartedly welcome our speakers at pop-ups, you all know that typically information that we put out, we vet completely, and that's not the case for these pop-up presentations. So we don't necessarily agree or disagree with the information that our speakers share, but again, we welcome them. And with that, I will introduce our speaker for today. Ann Young is joining us. Ann is a registered dietitian at the Pediatrics Clinic of Hennepin Healthcare, which is in Minnesota. So with that, I hope you all will join me in welcoming Ann. She will tell us a little bit more about herself in a moment.
So, hi everybody, I'm Ann. I am a registered dietitian. I work at Hennepin Healthcare, and the clinic that I work at is in Minneapolis, and I'm in the pediatrics clinic. So I work with kids and families. And a big part of my role in my job is in the growth and nutrition clinic that we have. And so this is a clinic where we see kids with growth concerns, poor weight gain, feeding difficulties, complex medical needs that involve nutrition. And it is a team approach. So when kids come into the clinic, they see me and a pediatrician in a joint visit. So we look at kind of the whole medical picture and how nutrition fits in there. And then we also work really closely with our speech and OT team who do feeding therapy with our patients. And then we also have a public health nurse that works with us that does some home visits for some of our patients. So it's a really nice team approach to working with kids that are struggling with growth in some way. And then there's that second picture there because I'm also a parent of a kiddo who has had his share of nutrition concerns as well. Jonah is 9 now. He has Down syndrome and he was on tube feeding for several years and continues to, work on feeding even now. So I kind of bring that perspective to this work as well. And that really informs the way that I work with families a lot of the time. And as a side note, I have so much appreciation for what all of you do. I remember when Jonah was getting early intervention services when he was tiny, and I can't tell you how many times my husband and I looked at each other and just wondered, like, how do other people raise children without a team of experts telling them what to do? I just don't know. So thank you for what you do, and I'm really excited to be here today and talk about nutrition. So I thought we'd start with assessment. Like when we're looking at growth and nutrition status, what are we looking for? So we measure weight and height, obviously. We look at that weight for length ratio in younger children. So the birth to three kids that you all are working with, we're looking at weight for length. We use BMI with older kids. Um, we look at weight gain velocity. So thinking about, are they growing and gaining weight at the rate that we would expect for their age? Mid upper arm circumference, we don't measure too often, but it is helpful in kids when it's hard to get a good length. So thinking about, for example, kids who come into the clinic with CP and they're really tight and it's just, there's no way we're going to stretch them out to get a good height, then we can't really get a weight for length ratio. So mid upper arm circumference is just another way to get kind of an estimate of body mass. And then in terms of nutrition status, we can also estimate kind of what their needs are. And then in conversation with families, think about, are they taking in what they need? Oh, why are we not advancing? There we go. And when we think about those energy needs, there are different factors that come into play. So age, when kids are, newborns need a lot more energy per body weight, just because they're growing so quickly. Height and weight, of course, a child's size determines or helps determine how much energy they need. Activity level, kids who are more active and moving around a lot are going to need more calories than kids who are less active. And then injury or illness also can make a difference. So if you have kids that you're seeing who are recovering from surgery or have had an injury, healing takes more calories, takes more energy. Those kids sometimes have more energy needs. Kids who are have a lot of respiratory issues, often they're working harder just to breathe. They might have higher energy needs. So those are all things that we think about when we think about how much a kiddo needs. Just a quick word about growth charts. You may have seen these before if you have kids of your own and you've been to the pediatrician with them. I won't get into the weeds too much about different types of growth charts, but I think the important thing to know here is we're not necessarily looking just at kind of where they are in the chart, right? There's a range you can see. We've got kids who are bigger and kids who are smaller, but we're looking at trends over time. And we're looking at, is this child kind of tracking along the curve where we would expect? And this is something that I use a lot in my practice, where as we're looking at the growth chart, this one happens to have Z-scores just because that's what we use when we think about diagnosing malnutrition, but often you'll see percentiles. So if we have a kiddo who's been tracking along at 70% for their whole life and all of a sudden they're still gaining weight, but they've slowed down and now they're at 50%. Well, like 50% looks fine if you haven't seen what they've done before, but that's a concern if it's a drop along the curve. So making sure that kids get in for those regular wellness visits is so important for lots of reasons, right? They need their immunizations and so on, but growth is one of those reasons because we want to catch that early if they start to kind of decline in their growth. In terms of malnutrition and a malnutrition diagnosis, just a little kind of definition. So this comes from the American Society for Parenteral and Enteral Nutrition. And they define malnutrition as an imbalance between nutrient requirements. Sorry, I lost it. I'll let you read it while I get my screen back. There we go. That may negatively affect growth, development, and other relevant outcomes. So it's a mismatch between what the child needs and what they're actually getting. And what does that look like when we kind of look at those measurements that we were talking about? It could be low weight for length or BMI. So, again, kids who are really, really skinny, right? They don't weigh as much as we would expect for their height. Slow weight gain, we talked a little bit about with the growth chart, if they're not gaining weight as fast as we would expect. Weight loss, any weight loss in a child under 2 meets criteria for a malnutrition diagnosis. Those really little ones should always be gaining weight. They should be growing. And then as kids get older, there's kind of criteria. If they lose 5% of their weight, then it's considered mild malnutrition, for example. So weight loss, we look at decreased weight for length or BMI can be related to either weight loss or slower weight gain than expected if they're not keeping up, if their weight isn't keeping up with their height growth. Um, Eventually, we might see growth stunting. Typically, we see weight fall off first before we see a change in their length or height. And then again, mid upper arm circumference, we don't measure um, all the time, but it can be helpful as well. And it can help if we're looking at, it's another criteria for a malnutrition diagnosis. And these are the kinds of things that I look at as a dietitian when I'm looking at a malnutrition diagnosis. Um, this is just a note about terminology, and I think this is really good news, in my opinion. We saw this year a change in terminology. So we're no longer describing children as failure to thrive, which failure is such a harsh word. And that term failure to thrive never really had a standard definition. So it has been replaced now with weight faltering, and we do have now specific criteria for diagnosis. So as providers are looking at growth, they're looking at these criteria. And again, I won't get into too many specifics about the numbers, but just knowing that if we're thinking about a kid with weight faltering, we're thinking about a low weight for length or a low BMI. In children younger than 2 years, if their weight gain is slower than it needs to be, or if they've had a decline in their weight for length, or BMI, so weight loss or slower weight that's not keeping up with height. Okay, so if we've kind of done all the measurements and we're talking to a family, they're in the clinic, what are some of the things that we talk about, factors that might be going on that might be impacting nutrition? GI concerns is a big one. Constipation is one that we see a lot, and kids don't want to eat, neither do adults when they're constipated. So, so that's a big one, but other kinds of GI concerns as well. So, if a kid is vomiting a lot and having losses, that's going to obviously impact their nutrition status. Some conditions like celiac, for example, can cause malabsorption, and then they're not absorbing the food that they're taking in. So all those things can impact nutrition status and growth. Dysphagia, I'm sure you're all familiar with, obviously impacts how much a child is taking in if they're not able to manage oral eating. And similarly with like sensory differences, oral aversion, things like that. Kids may not be eating as much as they need. Dental concerns I see more often than you might expect in the clinic. I'm thinking about a kid that we saw just a couple of weeks ago. A little 2-year-old came in, and parents were saying if she's not picky, she'll try anything, but she only ever eats a couple of bites. And, she just wants to drink milk all the time. And the pediatrician did her exam and looked in her mouth, and it was just full of cavities. So she wasn't complaining about dental pain to her parents, but that couldn't have been comfortable. And so we need to get that kiddo to a dentist to make sure that they get that taken care of, and then talk about hygiene and things like that. So that obviously also impacts what they take in. Food allergies, if a child's diet is really limited because they have multiple food allergies, or if we have a kiddo who's has some anxiety because they've had an allergic reaction, those can play a role. Food insecurity speaks for itself. We try to connect families with resources whenever we can, if that's needed. And then social stressors. So, stressful things are happening that can impact appetite as well. So when we do see a child who is malnourished, who is underweight, what do we do? So increase calories sounds pretty obvious. So we can do that in a couple ways. We can use food. Oral nutrition supplements are things like a Pediasure, like a nutrition drink, or other kind of medical food products that we can use. And we'll talk a little bit about those. Feeding therapy, if it's applicable for the situation. And then for kids who really can't meet their needs orally, then we look at nutrition support in the form of tube feeding or IV feeding if they can't do anything enterally. So when we think about adding calories through food, these are some things that I talk about with families. How can we add more calories with a small volume, right? So full fat dairy, whole milk, full fat yogurt, things like that for kids that need more calories. If you have kids who are on WIC unfortunately does not cover full fat dairy for kids over 2. So for those kiddos, sometimes if the family is using WIC and they're getting low fat milk, for example, sometimes we'll advise to add a little bit of powdered milk to the child's milk to add some calories and protein, or like a tablespoon of heavy cream if we're just looking for kind of calories and fat. So those are options. Anything with fat, oil, butter, cream, peanut butter, all those are going to give a nice boost of calories with a small amount for kids who are not taking a large volume. Condiments, same thing. Avocado is a great source of fat. And then jam, syrup, honey, obviously for kids over a year. Sometimes families are surprised that I'm recommending anything with sugar to them, but when you have kids who really just need calories first, then that's absolutely appropriate. And then we talked a little bit about powdered milk already. Sometimes we even have families that will like sprinkle the milk onto food or mix it in to add a little bit of extra calories and protein to things like rice or pasta, things like that. And then there's formula. So for infants, there are high calorie formulas out there. You might have seen NeoSure is one that is used with preterm babies. We can use, there's a medical formula called Fortini that's very high calorie formula for kids who like have a food restriction or really need more calories. We can concentrate formula. Sometimes we have families mix the formula to a higher concentration than the standard recipe. So we're just adding a little extra powder. If mom is pumping, fortifying breast milk is an option. So those are all kind of formula options for infants. And then in kids, older kids, nutrition supplements like Pediasure, there are lots of different ones out there, are sometimes an option. I typically try to steer families towards food first, just because sometimes when when kids get those supplements, if they really like that milkshake, sometimes it makes them not want other foods. But sometimes the supplement is really appropriate. So I use those supplements a lot with kids who have really very restrictive diets. So thinking about kids who have just a lot of sensory sensitivities and maybe they only eat 5 foods, right? So if they have really low variety, we might use a supplement to add calories, protein, and micronutrients. Kids who have difficulty with solid foods, if they're having trouble managing and getting enough with solids, we might use a supplement. And then sometimes we have patients who have really increased their calories with food, but just need more than they're able to get. And then a supplement would be something we'd use as well. Sometimes it's not just about the specific foods that the child is eating, but it also has a lot to do with the routine in terms of how or why they're not eating as much as they could be. So we can think about ways to change the eating routine to encourage hunger or interest in food. So frequency and duration of feeding. So sometimes we see kids who are kind of picking all day long, grazing, or parents who are really anxious about the fact that their child is eating small amounts and they're offering food really frequently, like every hour, every half hour, I'm giving them food all day long, right? And most kids just don't have time in between to feel hungry. So we talk a lot about spacing out those meals and snacks at least 2 hours, if not 3 apart, to really give kids time to feel hungry in between. And then duration of feeding too. We don't want kids sitting in the high chair, sitting at the table for really long periods of time. It doesn't make them eat more, and it often is stressful. So having a kind of a hard stop at whatever it is for the family, 20 minutes, say that we're gonna sit in the high chair and then we're gonna be done and come back later. Caloric beverages. So milk is a big one with toddlers, where if a kiddo has access to their bottle all day long and they're just sipping on milk, they're not going to be hungry for food. Sometimes it becomes kind of a cycle where, okay, we gave breakfast and they didn't eat much at breakfast, so then we're going to give them the milk because we know they'll drink the milk, but then they're drinking milk all morning and then we get to lunch and they don't want to eat lunch either. So when we talk about kind of that mealtime or snack time schedule, we'll often advise let's not give anything except for water in between those meals and snacks to make sure that they're not filling up on milk, and juice too. We really want to limit juice, for lots of reasons. Kids can fill up on juice too, and it doesn't have um, the nutrients that milk would have. And it's, for dental health too, the sugar is not good sitting on their little teeth. So, so kind of decreasing any kind of food or drink between meals other than water, and then making sure that the intake of milk is not so much that they're not hungry for their other foods. And the last two kind of can go together. Nighttime feeding. Obviously, if we're feeding a child, if they're getting up in the night and they're having a bottle, or they're breastfeeding all night long, they're often not hungry during the day. And, for toddlers, older toddlers, sometimes even the breastfeeding in the day can be getting in the way of their appetite. I never want to tell a mom, don't breastfeed. Like I don't do that. But, sometimes I'll have a family come in with, say, an 18-month-old or a 2-year-old, and, the kiddo is breastfeeding on demand throughout the day, and maybe they're co-sleeping and getting up several times in the night to breastfeed. And so then it does become a conversation about, this is breast milk, maternal breast milk is not meeting that child's needs anymore at this stage of their life. And I'll often start that conversation by just asking mom, like, what are your goals? How long do you want to keep breastfeeding? And what are you thinking about this? And I would say more often than not, moms will tell me, I'm ready to be done. But this, it's just really hard, right? They cry all the time. Or so I've had moms say, he won't let me stop. So then it just becomes a conversation about, how can we make this work for you so that we can wean or decrease breastfeeding so that we're having some appetite and some interest in foods. You may be familiar with Ellen Satter. Ellen Satter is a dietitian who has done a lot of writing about feeding young children. And she coined this term division of responsibility, which is the idea that in the feeding relationship, the adult and the child each have a role. So the adult's role is to kind of set the environment. The caregiver decides what foods to offer, when those meal times are going to be. So again, that kind of schedule, and where meals and snacks will be eaten. And then the child kind of in that context decides whether they will eat at all, how much they will eat, which foods they will eat. And this is based on the idea that people are born with kind of an intuitive understanding of how much we need, how much we're hungry for, and that we don't want to force or pressure kids to eat. And often that backfires, and they end up kind of fighting us more, and then they may lose that kind of intuition about listening to their body's cues. And for many children, this works well. A lot of it is just about teaching parents to trust that it's okay. It's okay if your toddler doesn't eat everything on the plate. It's okay if today they eat everything you give them and tomorrow they don't eat anything that you give them. It's normal for appetite to vary. It's okay if they don't eat their vegetables, right? Teaching parents to kind of take that pressure off of themselves to make their child eat, because that's not possible. It's not your job. And then also taking the pressure off of the kiddo. Sometimes parents, again, if they're feeling anxious, then the child is feeling a lot of pressure. And very often, if as that kind of pressure or forcing or bribing, if we can kind of reduce that on the part of the parent, the child does feel more comfortable exploring and trying new things. It doesn't work for everyone. It's not a one size fits all, but it's a nice starting place for families that are struggling with kind of picky eating, especially if it's in a toddler, because sometimes it's just kind of a normal developmental phase that the child is going through, and the parents are worried about it, where maybe they don't need to be, right? Maybe we can get past this stage. These are some resources for families that you may or may not be familiar with. So Feeding Matters, let's see if I can find them. So Feeding Matters is an organization that supports families with pediatric feeding disorders. So you see they have this nice family support. They have some good education things for families. And then they also have this, they call it the Power of Two parent mentor program, where families can be matched with, I think they call it a family coach. So someone who's been through something similar to what they're going through. So that's a nice organization for, again, kids and families with pediatric feeding disorders. And then Oli Foundation, you might be familiar with, is a support organization and advocacy for tube feeding and IV nutrition at home. And they also have some resources for patients and families. So some education, and then some kind of building community and connecting with other families. And that's it. That's all I got.